My clinical practicum location is efficient with its care across the continuum. Upon completing my research, the first care management element that highly resonated with me is that significant effort is placed in the patient and with not sufficient follow-up occurring outpatient. Many patients are readmitted, and this could be done and due to patients' care not being cohesive with follow-up. There are times that physicians are not aware a patient is readmitted to the hospital or patients fail to attend their follow-up appointments. While case managers, assistant managers, and discharge planners exist, there still seems to be a gap with the follow-up during discharge. Opportunities for growth and consistency would be for a liaison or a home health manager to ensure a patient understands their diagnosis, symptoms recognition, medication compliance, post follow-up visits, and rehabilitation program and treatment plan. A threat to implementing this is that my practicum facility contracts with third parties, therefore leaving ample opportunities for miscommunications and patients to not have follow-ups. Hospitals should consider partnering with primary care clinics to implement multifaceted transitions of care programs to significantly reduce the 30-day readmission rate. Another care management opportunity is to polish the stroke discharge checklist. Currently, many patients are readmitted, and data shows that those readmitted do not have a staff member review the checklisted targeted items for minimizing a patient's readmission probability. While the clinical facility I am at does a thorough job implementing efficient and effective programs, they do struggle with validating complete follow through for varying reasons. Discharge checklist allows staff to review and assess patients, understanding of discharge medications, catheters, home care plans, follow up, symptoms, and who to call with problems after discharge. In parallel, we developed a process of integrating the checklist into the process of discharge after routine discharge procedures were completed. Checklists were used to assess patients' level of understanding and need for additional education, as well as changes in discharge documentation. Also noted were good catches and significant errors in the discharge process. An opportunity for growth would be to interview staff on reasons a discharge checklist was not completed prior to discharge and areas of improvement to ensure it is completed. A threat to the program would again be compliance and cooperation with staffing and the facility to implement the discharge checklist communication. A third care management application is for my clinical facility to build and create their own acute rehab and skilled nursing facilities in an effort to ensure members are receiving quality care and that follow through on stroke patients is optimal to minimize readmission rates and probabilities. While the organization may have the ability to encourage and facilitate this change, it would take significant amount of time and resources. A threat would be creating a financial structure that would facilitate the success of the outpatient programs. According to an article by Hospital Case Management, to prevent readmissions when patients are transitioning from an acute care hospital to an inpatient rehabilitation center, case managers should make sure that the patients are appropriate for acute rehab, that their medical conditions are stable, and that they can tolerate 3 hours of physical therapy every day.